We've had a slight change in the agenda this evening. We're just shuffling some folks around. Dr. Moriarty is on his way as we speak, but we're going to kick off the program with Dr. Seth Martin's presentation. I think most of you know Dr. Martin, preventative cardiologist at Johns Hopkins and a pioneer in LDL apheresis, and he's going to speak about the importance of LDL-C reduction. Seth?
Thank you, Harry, so much. It's great to see some friendly faces in the audience, and please enjoy your dinners while I try to entertain you before Dr. Moriarty comes for the keynote lecture, and we're really going to hopefully keep this interactive and have, certainly feel free to interject with comments or questions along the way. I'd love to hear kind of feedback as we go through some of this. I think the beginning of this, here are my disclosures, is going to focus on just the importance of LDL, and I suspect most of this room is familiar with this, so you can, again, enjoy your dinner as I'm sharing some data that you're familiar with, but it's important to sort of start with the foundations, and then we'll review the types of patients that are not well controlled with existing therapy and understand and apply the new approved, FDA-approved LDL threshold for lipoprotein-apheresis patients and who have had prior ASCVD events. And if anyone in the audience has experience with these types of patients, I believe we were expecting a patient to join us as well. I'm not sure if they're here yet. Okay, so you are going to be hearing from a patient later with Dr. Moriarty, so that's super exciting. So I'm just the warm-up act here before we have the real deal later. So this is a slide that probably many of you are familiar with, from actually led by one of the fellows at the Brigham, Michael Silverman. He was one of my friends at Hopkins. He was an Osler resident at Hopkins before he went to the Brigham, and then he did this nice study with the TIMI group. And at that time, we were kind of in this, just before this, the world was all talking about how it's all the statin, and we're kind of getting away from LDL. It was almost like folks had a deficiency of statin that needed to be repleted, and we were moving away from LDL. And then Improve-It came out and showed that the amount of LDL reduction with ezetimibe on top of statin led to the expected risk reduction that you would have expected with a statin, but now this time with ezetimibe with a different drug in a totally different class. And then in that context, Dr. Silverman published this study in JAMA that really showed that the risk reduction shown here on the y-axis is proportional to the achieved LDL level. And whether it's from statin, of course we have most of our evidence there with 25 trials, but whether it's with PCSK9 inhibitor, there was one trial of ileal bypass, diet, niacin, fibrates, ezetimibe, the Improve-It trial specifically, or CTP inhibitors are a bit of an outlier. But with all those, you get the risk reduction is directly proportional to the LDL lowering. So it's very much about that LDL lowering. And although it seems a bit kind of simple to say tonight, there was a time where we had kind of, as a medical society, gotten away from this idea that it was directly tied to LDL. People thought it's just you need a statin to address risk, and it had very little to do with lipids. So the pendulum swung back. This was an article in the Lancet that I was really fortunate to be a part of, that was led by Rory Collins and the Oxford group. So this group has summarized all the evidence. It's really impressive if you read back their early papers. I mean, they had the foresight to start collecting all the high-quality evidence from statin trials, put it into one big database, and this is what we're going to use to be able to guide clinicians and patients on what the expected benefits are. And if you look at the decisions that we make in medical practice on a day-to-day basis, very little do we have as much evidence as we have for statin therapy and LDL lowering. And what this article summarizing all that wealth of evidence from hundreds of thousands of patients would say that the benefit in terms of heart attack reduction, preventing procedures like stenting, stroke reduction per 10,000 patients treated over 5 years, and if we reduce their LDL a reasonable amount, like 80 milligrams per deciliter, that you'd prevent 1,000 events in the secondary prevention setting and 500 events in the primary prevention setting. So we're having their risk of life-threatening vascular events, and the harms are really outweighed by the amount of benefit you get from LDL lowering. So about 5 myopathy events, 5 to 10 hemorrhagic strokes, newly diagnosed diabetes, 50 to 100 more. And really, often those are folks who are already on their way to diabetes, and the process is accelerated. And really, the best thing you can do there is to improve lifestyle habits. It's not like this came out of the blue that someone developed diabetes. And so these adverse effects are really outweighed by statin therapy. This article, frankly, was in response to a lot of misleading claims that were being perpetuated in the media. This was really rampant in the UK, but also in the US and other countries. And this was really infuriating all these incredible physicians and researchers who had generated this high quality evidence over decades to have that refuted by groups that had never performed a high quality research study themselves, to start talking to the media about all the concerns they had that were really not substantiated. So this article was like 30 pages or something in the Lancet, and really a response to that, discussing in incredible detail how you actually interpret clinical evidence. This is a slide that emphasizes that although we get far with statins, we have further that we can go. And so these are really the exciting data that we received from all that led the PCSK9 trial work. And this highlights Fourier, and after Fourier we had Odyssey outcomes. And here the reduction in LDL cholesterol falls on the line that we would expect. The amount of LDL reduction leads to the same amount of risk reduction. And I think subsequent slides show this, but basically for every 40 milligram per deciliter lowering of LDL, we expect about a 25% relative risk reduction in cardiovascular disease. This slide also emphasizes the importance of the trial duration. When we're treating LDL in clinical practice, we're talking about treating for decades, and the trials, that's just not practical to treat for decades. So we're getting evidence from 5 years for statin trials, or even less, and in the case of PCSK9 trials, 2 to 3 years. So we need to take that into account. We're able to detect the cardiovascular benefit in that short window, which is amazing that we can detect the benefit, but the benefits we would expect to accrue to much larger levels as we treat patients over longer periods of time. Again, difficult to study, but very reasonable to assume that those benefits would accrue over the long term. All of this evidence on statins and non-statins has been summarized in the 2018 ACC/AHA guidelines, and even more recently by the European guidelines, which are largely similar but have some difference in the way that they operationalize the evidence. But here in the secondary prevention setting, clinical ASCVD, interestingly in the European guidelines, their very high risk category can include either primary or secondary prevention, with the primary group having, if you have extensive subclinical atherosclerosis, can get into that group. It all starts with a healthy lifestyle, just like you all are doing right now, exercising and eating healthy dinner here. It starts with that healthy lifestyle. And then you, if you're very high risk, you go to high intensity maximal statin therapy. That's a class 1 recommendation, again, based on all the beautiful evidence from the cholesterol treatment trialist group. And then the guidelines really emphasize this step of using ezetimibe before the PCSK9 inhibitor, but this is a hotly debated topic of really, can you get 20% or you get 60% LDL lowering and more benefit with PCSK9 inhibitor? But the guidelines felt that because ezetimibe was oral and generic, although it's not always cheap, but it is generic, that should be the next step. And then if on clinically indicated maximal LDL lowering with LDL 70 or more, or non-HDL 100 or more, adding a PCSK9 is reasonable, and that's a class 2A recommendation, so as close as you can get to the 1A, to the one recommendation. I wanted to share the story, before we even got to these clinical trials that showed the clear benefits of PCSK9 inhibitors and ezetimibe on top of statin therapy. If you look at the genetic evidence dating back to 2006, this was inspired by the finding in a French family that who had too much activity of PCSK9, that had familial hypercholesterolemia phenotype with developing heart disease and xanthomas. Dr. Moriarty has arrived. Excellent. Just so we'll in terms of the story here, so that led to PCSK9. I sort of jumped to that, but it was an amazing translation of evidence over 10 years from this discovery in a French family that had really high levels. Now it led researchers to find folks that had actually low PCSK9. They were genetically born with low PCSK9. And there you see this shift in LDL levels compared to the normal American population to much lower levels, including some people that tend to live with levels well below 100, even some below 50, and are very strongly protected against coronary heart disease. So this is really exciting and really prompted a lot of the then work that led to the development of drug therapy to mimic this. And what I want to emphasize is that those folks that have those genetic mutations that lead to low lifelong LDL, not only are they protected from heart disease, but appears to be completely safe. There's no adverse effects that come from those lifelong low LDLs. There's been some folks who inherited that gene from both mom and dad and live with a LDL of 14 through their life, and they really just appear to have benefits. And this was confirmed over 2.2 years in the Fourier trial. This is a really nice study presented by Dr. Bob Gugliano at ESC and published in The Lancet that showed that risk reduction really, as you get down lower and lower and lower, this is LDL getting to 58, 39, 19, down to 0, the event rate just goes lower and lower and lower in terms of the composite of cardiovascular death, MI, revascularization, hospitalization for unstable angina. This is really important information because when I was a cardiology fellow, it was thought that, yeah, you get below 70 and it sort of seems to plateau. The lower you go, it doesn't seem to matter that much more. You can't really do much better. These data would argue against that the lower you go, the better. And it was very safe to do that over 2.2 years. Here's the safety data comparing those that had an LDL on treatment less than 10 versus 100 or more. And they had exactly the same proportions here in terms of serious adverse events and events that led to drug discontinuation. Exactly the same, 3.4%. And Dr. Moriarty, you're getting your slides loaded up here. It's about 7 o'clock now. So what time are you thinking in terms of, we want to make sure we have time for audience participation. When were you hoping to get going? That'll help me titrate how quickly I go through the, okay, all right. Well, just to share a little bit about my own work, so one issue is it safe to go to very low LDL levels? And the data are saying yes, genetic data, clinical trial data. Another question, but yet I think a lot of physicians and patients still have concerns. That's what I've seen in clinical practice. So another question that comes up is the LDL being assessed accurately? Back when I was a medical student or resident, I didn't even really think about that question. I thought, of course, it's being measured accurately. This is LDL, this is bad cholesterol, this is what we use every day in clinical practice. Why would you even think to ask, is that being assessed accurately? Well, when I joined cardiology fellowship, I started thinking about that question, and I was amazed to learn that this was being calculated by an equation that some studies in kind of obscure journals had suggested maybe was not so accurate. And I started looking into this. What we found in a very large database was that there was a really strong tendency at low LDL levels towards underestimation of bad cholesterol. And the concern there is that underestimation could lead to undertreatment. So although in the past this may not have been such a big issue because we didn't have all these drugs, we had a healthy diet, we had Cheerios to help lower your LDL cholesterol. Now that we have all these fancy drugs, you got to take this accuracy issue a little more seriously. And so although the original developer of that calculation had said that this would become an issue, it really hadn't become a mainstream issue in the medical community, the cardiovascular community. But this paper we were able to get into a prominent cardiovascular journal and I think started triggering people to think more about this. We were fortunate to be able to publish then an equation that improved upon the fixed method where we sort of treated everyone in this room. We're going to calculate your cholesterol the same way versus a more precise way to adjust the way that it was assessed. And we showed a clear improvement in our database, but at that point still had very little clue whether that would be able to be replicated by other researchers. Fortunately, it's been extensively replicated around the world, including by one member in the room tonight. And we then thought about how could this actually be implemented. And I think the ideal solution is to integrate better assessment in the lab information systems. It turns out that that's not as easy as I would have thought it would be. In the meantime, we put out an app that you can just plug in the total cholesterol, HDL, triglycerides, and calculate it. So it's been very satisfying to see that we've moved the needle on providing better information for patients and clinicians to make decisions. And we've really inspired people to take this issue seriously. I'm going to really kind of keep going quickly, maybe over the next 10, 15 minutes, try to wrap up so we can get to the highlight of tonight here. But I want to shift towards talking a little about familial hypercholesterolemia. So this slide really emphasizes that as you have a patient with FH, and if you let that go untreated, the curve starts really going upward. And so this is cardiovascular mortality, about 50% by age 60 if FH is left untreated. So we really want to get ahead of this curve. These are pictures from my clinic just showing FH findings. So this is corneal arcus here you see in the eye. I don't think this is showing up so great on the screen, but these are xanthomas in the extensor tendons of the hands, the thickened Achilles tendon that you can see bulging out here rather than having the nice inward curvature, and xanthelasmas under the eye there. And really being born with high LDL, you can think about it like pack years of smoking. You're exposed to so many years of high LDL. That is really what drives atherosclerotic risk. So I want to shift to, now towards apheresis, and I think my colleague, Dr. Moriarty, is really the world's expert here and is going to get into more of these points. But we just wanted to start by sharing this really classic study from 2006 by Thompson et al. And I think the main points here are that you get this, apheresis is on an every 2-week basis, and you get this very quick acute drop, and then there's the rebound, and the drop and the rebound. But after 2-3 months or so, you really start to level out. And if someone's on an aggressive background medical therapy, maybe that could level out sooner. This is an older study on less background therapy than we have now. But really what we focus in on eventually is that average effect, what's going to cause the cardiovascular risk is this baseline LDL, the mean effect. Dr. Moriarty, is there anything you would add on this slide here?
No, I think you explained it well. I'll bring up something.
Okay. Sounds good. This slide just shows, really, you can take someone who has homozygous FH, has sky-high LDL levels to begin with, and given all that we have access to in 2019, if you start that statin that the cholesterol treatment trial has taught us about, and ezetimibe, and now a PCSK9 inhibitor plus apheresis, you can actually get a HoFH patient down to very reasonable LDL levels. And this is going to improve cardiovascular risk, going to protect against cardiovascular events. In terms of apheresis, this was a really critical classic study from the late 1990s in FH patients with CHD. And they compared those who got apheresis plus meds versus meds only. The average, as we'd expect, the interval for apheresis was basically 2 weeks. They were followed up over 6 years for coronary events, non-fatal MI, stenting, bypass surgery, coronary death. This is the table just comparing baseline characteristics of these groups. We see they had a similar age in the high 50s, which is like kind of what we see in most cardiovascular studies around there. They were 3/4 men in each group. We see the risk factor burden. So about quarter of folks had diabetes in each group. Bypass surgery was present in 10 to 20% of folks. The Achilles tendon thickness was a little bit higher in the apheresis group of 16.5 millimeters. And then we see most patients were on statin medications, and this study predated ezetimibe and PCSK9 inhibitors. And then again, follow-up for 6 years. So here we see the lipid numbers. So if we focus in on LDL cholesterol, it went from 288 to 122 on treatment. So basically a 60% reduction. And then the meds group came down 20%, 28%. And then you can see the total cholesterol is pretty similar, but the LDL being the main effect. And then here the triglycerides were pretty well controlled in both groups, so that wasn't really a big issue. So this is the results for CHD event rates shown the proportion without any event. So this is like the kind of classic Kaplan-Meier curve over 10 years. You see the better outcomes amongst the lipoprotein-apheresis group, whereas the medication group is coming down here. So the relative difference is a 72% protection against CHD events in the apheresis group. This is a very well-tolerated procedure. I guess you may hear more about that later. Hypotension is something we think about a lot, but it just doesn't occur much when undergoing the procedure. There is really, I think, consistent practice across centers to avoid ACE inhibitors, and that was done in this particular study, but adverse effects are really uncommon. You see less than 1% for each adverse effect. And yeah, anything else you would add about that, Dr. Moriarty? It's really just well tolerated.
Simple apheresis side effects
Yeah.
are the same no matter what procedure.
Yeah, yeah,
Very
yeah,
rare.
yeah. This is the machine. I must admit, as a cardiologist, I'm not like an expert on the machine, because my colleagues in the transfusion medicine center run this, and so I wouldn't be able to tell you I've turned all the buttons and everything on the machine and all that. But this is what it looks like, and I mean it's kind of reminds me of a dialysis machine. When our patients come in there, I mean it's kind of like what I'd be curious to hear thoughts as well. I mean it kind of becomes like a sort of friends and family kind of thing. I mean they become some of my patients very attached to their particular nurse who runs the machine. That can make a big difference, just that experience. It's not about, hey, I'm just going in to have a robot, run this. It's part of it is that human factor of who's actually, getting access and for you. And I think that actually it can become, in some ways, although no one would choose to say, I want to, undergo this every 2 weeks, but it can actually become kind of a nice personal experience in that way. So it can be run, through a peripheral catheter or central. The blood's withdrawn. It goes through the plasma separator, and the blood is returned. This shows what happens in that process. So there's the cellulose beads with dextran sulfate, and this negative charge connects with the ApoB with a positive charge. And so what we're removing is only the ApoB containing particles, which is present on low density lipoprotein and very low density lipoprotein, not the HDL particles. Anything you would add at the moment? You may expand on some of this later. Okay. The top part of this slide, for some reason, isn't projecting great, but this is really critically important information on this slide. It is the new lower LDL threshold for LDL apheresis. So this is from the FDA, and so towards the beginning of the talk, I was showing the familial hypercholesterolemia population, and so thinking about that group of patients, which, by the way, affects more than 1 million people in this country have heterozygous FH. The latest estimates are 1 in 250. And so, whereas the homozygote FH is much less common. So their group A is considered those with functional hypercholesterolemic homozygotes with LDL greater than 500, kind of like that one curve I had shown starting up that high. Group B is those who were heterozygote, inherited from either mom or dad, with LDL 300 or more. And then group C is those with LDL 100 or more and either documented coronary disease or peripheral arterial disease. So this new group C lowers this threshold for secondary prevention down to 100 milligrams per deciliter, which really fits with the emerging evidence that the lower the better, and that we need to get to very ultra low LDL levels in very high risk patients. So it's been nice to see this progression of the indications to match the latest evidence showing that lower is better. And my understanding is that the insurance companies are very strongly recognizing this new FDA indication. Maybe sometimes they need a letter sent to them, but they are recognizing it very strongly. So in summary, just going to bring all these up here actually just for sake of time. So lipoprotein-apheresis, so there's selective removal of LDL, LPA. These are containing that ApoB lipoprotein. There's acute reduction of 60-80%, and about this sort of time average reduction of about 60%. There's little or no reduction in HDL, albumin, and there's reduction in atherosclerotic cardiovascular disease consistent with what Michael Silverman would predict in that JAMA paper, showing that the benefits are LDL dependent or ApoB lipoprotein dependent. And this is a safety net, I would say, an important option for patients who have the highest LDL levels. Certainly the homozygote population, the heterozygote population who may struggle with some of the statins or non-statin drugs to get well controlled, and then a few other patients. Certainly we know, we're not really getting too much into it tonight, we know that there's a huge problem with statin intolerance. It's very common. That's part of the reason that it's nice to have alternatives. We talked about, again, just to reinforce the new FDA indication, 100 or more if prior ASCVD. So I think this needs to be done by lipidologists as specialists, and we really need to get the word out for folks to refer these patients, for them to know it's an option. I know talking to some patients who are part of the FH Foundation, I mean, they found out about apheresis for the first time when they were at like a FH meeting, amongst patients. They didn't find out from a clinician about this option. So we need to get the word out. Take-home points, LDL reduction is highly evidence-based and critically important. FH is underdiagnosed, undertreated. It's thought that only 10% are diagnosed, so we really need to get the word out. Guidelines recommend max tolerated statin therapy followed by ezetimibe and PCSK9 inhibitors, but LDL may still be inadequately controlled. Lipoprotein-apheresis is another option to reduce atherogenic lipid burden and risk. LDL is the garbage of lipid metabolism, and really the genetic and clinical trial studies are saying that there's not a level that's too low. This new FDA Group C lowers the threshold from 160 to 100 in those with documented CAD or PAD. And patients really, as I said, need to be referred for advanced therapy. So thank you very much. I'm going to turn it over to my colleague, Dr. Moriarty.
I like that statement, the garbage of metabolism for LDL. And
Good evening, everybody. I'm sorry I got late. My 1 hour flight became a 3 hour tour. And but I got here. And I want to move quickly on my slides because the star of tonight is over here at the table. So we'll talk about her shortly. But let me move ahead with this. And I'm going to jump quick. So one thing I talk about when I talk to people that do apheresis, because the hematologists, nephrologists have this big belief that plasma exchange can do the same thing as lipid apheresis. And these are some studies showing you that it can't. Where's the lead? So here's plasma exchange. Here's the dextrin sulfate. Look at the HDL reduction that you see here, a major difference. And look at the rebound of LDL, total cholesterol with plasma exchange compared to apheresis. Look at the rebound of HDL plasma exchange. Look at it's minus 60%, and the rebound's only 8% after 5 days, where it's only 15% for apheresis. So the HDL does go down modestly. I'll talk about that in a minute, but it goes up quickly. Why does HDL go down modestly? Well, HDL is a positive charge molecule, as Dr. Martin showed you. ApoB has a negative as a positive charge. And we use a negative charge environment, dextrin sulfate, to capture the ApoB and other lipoproteins that are proathogenic, where HDL is negative charge. But some HDL is taken away. And I've worked with Jay Heineke's group out in Washington, and we've looked at this. We presented this in Munich last year at the ESC, that we actually change CEC. We actually changed the ApoCA1 specific CEC. And with apheresis, we reduce it by 10 to 18%. And then we look at the HDL. We actually reduce small condensed HDL, which is actually not really very good HDL, and we increase large, buoyant, large HDL. Additionally, look at what we remove from HDL. We actually increase the how do I go backwards? We increase the ApoA1, we increase the ApoA2, LCAT is increased on HDL, PON3 is increased, where ApoB is bound to HDL. I think Bob Rosenson has been talking about this for years. ApoE is bound to it, we published that years ago. ApoC3 is bound to it, and we removed that. Lp(a), there's a little Lp(a) bound to HDL that we never known about, but with the proteomics, we're able to find that out. And serum amyloid A, which is a very major pro-atherogenic, pro-inflammatory marker, is reduced by almost 30% with apheresis. So we're reducing bad HDL. Why are we reducing these HDL? These proteins here, I'm sorry, go on, have like a negative charge to it, particularly ApoE4. We found as a negative charge, as a positive charge compared to ApoE2 and 3. So we do remove HDL selectively, interesting or not. These are other things we remove with apheresis. Very important procoagulant, pro-inflammatory markers that also remove with apheresis. So what I'm trying to tell you the story is apheresis does more than just lower LDL. It's a very, very, after 20 years I've been working with this, it's an amazing process of therapy for the vascular patient. This I always like to bring up is rheology. And this is a major player in vascular disease. Why disease occurs in certain arteries is because of blood viscosity and blood rheology, where blood flow is either stagnant or reverse, causing the blood viscosity to go up and damage to arterial walls. And if you remember the formula from your old days, viscosity equals resistance over 8 times the length divided by pi to the radius to the 4th power, or shear stress equals shear rate. Blood being a non-Newtonian fluid, when different shear stresses are put upon it, its resistance to flow, its viscosity goes sky high, where water and plasma never changes because they're so-called Newtonian fluids. Why is that important? Well, unfortunately, you can't see here, but if you look at normal veins during the cardiac cycle, the shear stress is always positive. Normal arteries positive. And arteries that are prone to atherosclerosis, during the cardiac cycle, blood is either stagnant or reverse at one moment, which causes the resistance to flow to go up very high because they're non-Newtonian. And this is a great example of this in the coronaries. We know the coronaries, arterioles dictate vascular resistance, but that's during rest. And during rest, the capillaries have about a 20% correlation, where the veins are about 15%. But during stress, ischemia and so forth, the arterioles are maximally dilated, and what takes over vascular resistance at that point are the capillaries. And what dictates flow in the capillaries, because you can't change the length or the radius, is the viscosity of that fluid. Simple physics. And as we know now, this is the belief of how atherosclerosis develops with endothelial shear stress, which can be either high shear stress, which causes fiber proliferation, physiological shear stress, or the low shear stress, as I mentioned, which can cause the acute coronary event. And I'm going, these are mediators of blood viscosity. Let me move ahead because this, so why I'm bringing this up is apheresis. And we showed this, hate to say almost 15 years ago, that apheresis lowers blood viscosity by 20% or more. So we're changing the blood from a very viscous fluid. I tell my patients from like ketchup to like tomato juice. So the microvascular perfusion in these patients is much more improved. So besides lowering the cardiovascular risk, these patients actually feel better because they're getting microvascular perfusion to tissues they weren't before: heart, lung, brain, muscle, and so forth. So all of them feel this. And if they have a history of chronic angina, their angina is greatly improved by this therapy. And they know when they need the next therapy because their symptoms are returning back. This is an example from Klaus Melrick from Germany showing a vasodilatory capacity 18 hours after the last lipid apheresis therapy. This is looking at myocardial blood flow, coronary flow resistance, minimal coronary artery resistance. This is 18 hours, showing a dramatic increase in just 18 hours after apheresis therapy. I made this topic about potpourri, so I wanted to go through some different diseases that are being treated around the world. In Japan, they have indications for specifically for treating PAD, and they've been doing this for over 20 years. These are the recommendations that they use. FSGS, focal segmental glomerulosclerosis. It's a very common complication pre or post kidney transplant. And apheresis has been used in Japan for the last 20 years or more. And basically, it's 12 treatments over a 3-month period. And in Japan, they have 500 to 800,000 patients have Fontaine classification 2 to 4 of PAD. And current patient number on lipid apheresis for this is 1,600 patients are being treated just for PAD. Here's an example of a female on dialysis who had atherosclerotic cardiovascular disease, left foot, thumb with ulcer. You could see after first, 7th, 10th, 8 months after treatment, the improvement of this patient's disease. This is a study by one of their groups, Toshida, looking at ABI, maximal tolerated walking distance, and other recovery ability index, showing a great improvement in these patients by going on apheresis. Because again, it's increasing microvascular perfusion, a major complication for these patients. And presently, as you know, the therapy for PAD is amputation for most patients, particularly our diabetics. Here's one more view of this of a diabetic looking at before and after 5 months of apheresis. Well, in the United States, in 2016 or 17, the United States approved the use of lipid apheresis, particularly the Lipoprotein-Apheresis system, for patients with primary focal segmental glomerulosclerosis, either before or after transplant. I actually have 2 pediatric patients I'm treating now who are post-kidney transplants that have tried plasma exchange for a year, did not get better, and now we're doing apheresis on them in my clinic at this moment. This is the hypothesis of why lipids have a nephrotoxicity. I won't go through that tonight. This is this retrospective survey of outcomes in patients. Unfortunately, it's hard to see, but this is looking at 2-year outcome. This is looking at 5-year outcome. So this is showing that complete remission occurred in 41% of the patients. Complete remission. And after 5 years, you still had 53% in complete remission using apheresis, lipid apheresis. Incredible data. Nephrologists in the United States are now really getting very much involved with this as a therapeutic regimen. Here's another thing that's kind of interesting. This was in Germany. In Germany, in the United States, when we have acute deafness, unilateral deafness, what happens? You see your primary care doctor, says, well, give it a week, you probably got a virus. It'll go away. After a week, if it's still there, let's go see an ENT fellow. That person will probably start you on steroids maybe. And after 2 weeks, if it's not improved, then eventually you're going down the road of cochlear implant. Well, in Germany, what they do is they hospitalize patients with acute deafness. They put them on IV fluids. In this study, they actually, this is for unilateral idiopathic acute deafness. If you can see the vasculature of the cochlear blood vessels, it's pretty torturous, very, very torturous. And this study by Suckful, he's an ENT physician in Germany, looked at treating LDLs and looking at patients with high LDL and low LDL, and looked at the change in hearing. And they found a dramatic improvement. And then when they looked at the fibrinogen level, which is a major player for viscosity, they found the ones with the high fibrinogen actually did much, much better. Another disease that you wouldn't believe this is effective, but so-called non-arteritic acute anterior ischemic optic neuropathy. It's the most common cause of acute blindness in the United States. And it's not to do with thrombus. It's due to high viscosity due to certain problems. And I'll show you one of our case studies. This is a colleague of mine, a Rumini from Italy, and he published this paper on his studies showing 11 patients who had this disease, and after treatment showing a significant improvement on patients' vision. I'll show you my patient. This was a case study we had at KU, again, about 15 years ago. It was a 29-year-old woman with a history of CNS lupus times 3 months, medication she was on IV steroids, Cytoxan, prednisone, and after she had a 3-day history of acute right-eye blindness, angiogram showed branch retinal artery occlusion, and also called NION. Labs showed a total cholesterol of 336, trigs 329, HDL, and LDL actually of 251. So the ophthalmologist called me and asked me what we suggested. So what we did, we put her on apheresis, and I'll show you what happened. Cholesterol went from 251 after that, down to 54, so almost an 80% reduction. I also looked at viscosity changes, and her blood viscosity at a high shear rate went down by 24%, and a low shear rate, which is the most viscous part, it went down by 32%. And this is her angiogram. This is her angiogram before. You can see how see this cobblestone look? That was read out by the radiologist as high viscosity occlusion. That's why this person was getting blindness. And this is after 4 treatments. Vision returned. Now, I just got back from Paris from the ESC meeting, and they had some incredible presentations on the new guidelines, which I was quite happy to see. And they have now gone down to an LDL they recommend to 55 for people with severe cardiovascular disease. Actually below 40 if you have repetitive events, if you're secondary prevention. They mentioned going down to 40, which I think, as Dr. Martin so eloquently talked about, that it's a garbage metabolism of cholesterol, and it has no clinical physiological benefit. And the lower we get LDL, the better off you are. And I think as we get older, probably 10, 20 years from now, LDL will be a toxin. It will be treated as a toxin. And the sooner you get it out of our system, because vascular disease takes decades to develop it, the sooner we can eradicate disease, as he mentioned, longevity like tobacco years. And I think that's what's coming, but we have a way to go. What also was interesting, which I found very nice, is they actually recommended doing carotid IMT, which we've been doing in our clinic for 20 years. Europe does it, has been doing it also. They finally recommended adding that to the regimen of analysis of asymptomatic disease. And of course, they have calcium scoring. But what really brought my attention was they mentioned universal testing for Lp(a). I think that needs to be done. It should be done. It should be in all the patients at least once, as you know, because it's a one-time measurement. If it's normal, you're pretty well okay. And it's already being done in the United States. Oh, before I get to this, in Germany, for the last 10 years, they've been using apheresis for patients with LDLs greater than 60, Lp(a) is greater than 60 milligrams per deciliter with ongoing cardiovascular disease. And these are 3 separate trials, Jaeger, Yosada, and Liebman, looking at patients with kind of baseline LDLs that weren't high, but high Lp(a)s, and looking at their MACE events, total MACE per year reduction, showing a dramatic reduction of events. Is it reducing Lp(a)? Is it reducing the viscosity? Is it reducing the inflammation? And the answer to that is yes, to all of those. But it works. Well, I'm proud to say Konica, with my help, has submitted a PMA to the FDA last month recommending treatment of Lp(a) with vascular disease and LDLs and Lp(a) is greater than 60. We had a meeting with the FDA a couple times, and the meeting went extremely well, believe it or not. Their biggest fear was not the Lp(a) story. They thought we'd lower the LDL too much. That was their biggest fear, that the LDL would go down too low. So we kind of made a compromise, and we're waiting to hear back. It takes 180 days to do that, so we should hear back at the beginning of next year. So we might be seeing lipid apheresis being used for this orphan patient population that right now has no therapy. And this year, the American Society for Apheresis had their 2019 guidelines, and in their 2019 guidelines, they recommended the treatment for Lp(a) greater than 50 milligrams per deciliter with CVD. They assigned a category 2 with a grade 1B to the recommendation. A category 2 is defined as their second-line therapy, either standard care, standalone care, or conjunction with other therapies. And a grade B is considered a strong recommendation with moderate quality evidence and can apply to most patients in most situations without reservations. That's a strong statement by this organization, which I'm very proud that they did that. I think I presented this before. This is a case of, this is from our clinic. We treat about 60 patients now in apheresis. And a good percentage of them have high Lp(a). This is a paper that's under review now in JCL, where we had 15 patients whose LDLs were, corrected LDLs were pretty normal and very low. But their Lp(a)s were extremely high. And we looked at their event rate before, and this is 4 years later, a mean of 4 years. We show about a 96% reduction of events. The only events that occurred in these 15 patients were a stent was administered to 2 patients. And that was it, nothing more. Where previously they had stroke, cardiovascular events, they were all secondary prevention. And they're doing extremely well. And this is something you might not know, because in adults, the majority of thrombotic strokes associated with atherosclerosis. Compared to children or adolescents, it's only 2%. A thrombotic strokes is related to atherosclerosis. There's no plaque in these patients. And we know in patients under 55 years of age, cryptogenic strokes account for almost 40% of all ischemic strokes. 40%. We have no idea why they're having strokes. Children with elevated Lp(a) have a 4-fold increased risk of acute stroke, and the risk of recurrent ischemic stroke, which is normally 5 to 15%, is increased more than 10 times in patients with an elevated Lp(a) above the 90th percentile. So a lot of pediatric neurologists that deal with pediatric strokes are looking at this now as a marker of potential strokes in these young patients. And it's something you should consider too if you have these kind of patients in your clinical practice. I'll end this before I bring in the star. This is one of my patients that had stroke, a 11-year-old boy who was referred to us from the Children's Hospital. And these were he developed these neurological deficits at the Children's Hospital. They thought it was first a hemorrhagic stroke, but then he finally realized that it was not. It was more of a thrombotic, and therapy was not improving the patient's outcome. He had a basilar artery thrombus that was not dissolving, so he came to KU and had the invasive radiology team do a thrombectomy on him. And after the thrombectomy, this is before, that's the thrombectomy, he still had symptoms. His symptoms were not resolving. So they did some blood work on him, and they looked up his whole coagulation pathway. Everything was fine. Then they looked at everything else, and lo and behold, way over here, this little guy was extremely elevated. Now his LDL was pretty normal, but everything else was totally normal except for the Lp(a). They called me in and they asked what I'd recommend, so we decided to do apheresis. And this is what the numbers before apheresis, after Lp(a) 148 down to 28, showed an 80% reduction. And this was what happened after apheresis. increased flow. He's now been on treatment now for 4 years. He hasn't had a recurrent event where previously he was having multiple events. And he comes in every 2 weeks, and his parents ask me, when can we stop? And I say, when we get a new drug, because I don't have an answer. And none of my colleagues in Europe who do this a lot more than I do don't have an answer either. And they say, you have to keep on treating him until we figure this out. His sister has a higher level than him. His mother has a higher level than him. We're doing some genetic work with Marlis Kaczynski up in Canada, comparing the 3 patients and seeing if there's anything genetically different between this young boy, his mother, and his sister. So that'd be kind of interesting. Now we come to the star. This is Aubrey. Oh. And Aubrey came to us a few years ago as a young 5-year-old girl from Sioux City, South Dakota. And she was referred to me by a pediatric cardiologist up there who was treating her for her dyslipidemia. She's a homozygote FH. She had LDLs in the 900s, and she was on statins, resins, ezetimibe, and we tried her even on a PCSK9 inhibitor, and nothing happened. It got down to 800s. She's a null receptor homozygote FH, so nothing was responding. So we put her on apheresis. It was tough in the beginning because we tried vein to vein, then we had to do a fistula on her, and she's been a trooper through all of this and has done very well. And now her baseline LDL before therapy is 450, and post is in the 60s. And let me show you, I asked Aubrey and her mother and her grandmother, which I'm going to bring up to you shortly after I show this, and about if I could show these slides, and they agreed. So this is her. Yeah, the lighting here is terrible for this, but you can see this real bumpy xanthoma here. She was wearing some pink outfit that day. She always comes in with colorful clothing. And my nurses give her gifts all the time, so she loves coming in. So she comes down from Sioux City, Iowa, which is a pretty far away, Sioux City, South Dakota. So that's it after. You can hardly see it. There's no bump there anymore. This is her. You can see these are very painful and very, very swollen and erythematous, and they just look angry. So this is before we started apheresis, and now these are them now. They've really come down quite dramatically over the year that we've been treating her, and she's been very, very good and very, very responsive to therapy. And finally, this is her again. This is her mother. This is Luba, one of my nurses, and this is Jennifer, one of my other nurses. My other nurse was on vacation. We have 3 nurses. And so I'd like to bring up now Aubrey and her family, her mother who has FH, her grandmother who has FH, but her grandmother is on the FH Foundation Advisory Council as an advocate. So I'd like you 3 to come on up if you can. Can you come up, Aubrey? Huh? Can you come up? Mom? And this is her dad, too, who does not have FH. Well, he does have some FH, yes. All 4 of them do, obviously, because she's homozygote. Okay. But you want to say anything to the audience? No. Well, I know who would want to say something. Grandma?
Just thank you guys all for what you do. It means the world to our family and other families like us. The FH Foundation has really helped us. That's why I'm really proud to be an advocate for them. And we'll do whatever we can to get the word out and get these little ones the treatment they so desperately need.
Dad? Let Dad.
I'd just like to thank Dr. Moriarty. It's a long trip to go down there to Kansas City and stuff, but I mean, if it was closer, I think we would opt to come to Kansas City still. You and your nurses are almost like a second family, and we're just thankful for everything you guys do. And I'm just glad to see the improvement she's made, and just thank you guys a lot.
Well, thank you. You going to say anything, Aubrey?
I say thank you.
Say thank you.
Thank you.
Okay. All right, that's enough from Aubrey. All right, thank you, guys. And thank Conica for letting them come here for the trip. I have to say we're doing a compassionate care request to the FDA to get her on angiopoietin like 3. Regeneron has been very kind to help us with that, and we'll be shortly submitting the request to the FDA. So hopefully we can either reduce her treatments or maybe even eradicate her need of treatments as time goes on. So we're hoping to get that going sometime this year. So with that being said, why don't we come back up, Seth, if you guys have any questions. I thank you for your extra time. I apologize for coming in late, and I'm running through these slides. I probably should have made them much shorter, but thank you. Any questions? Yes, Jim Falco from Colorado.
The patient with the basilar stroke,
Yes.
is that patient on anticoagulation too?
No, actually. Well, he's on aspirin. Yes, he's on aspirin, but there was nothing there that we thought it was necessary to put him on a Plavix or something of that nature. How many in here? Yes.
Sorry, just
Yes, yes. Right. Yeah. Well, that's a good question. The eye, kind of like the heart. The heart goes into hibernation. The eyes do too, in a sense, when they have not enough vascular flow, and the ears do also. We've done treatment for the acute unilateral deafness for the ears, and when I find out if you wait more than 2 weeks, forget about it. It's not going to come back after 2 weeks because that's the end of their hibernation period. For the eyes, I think it's much shorter, and also it depends on how much occlusion is going on, as you saw there. And so it's a combination of that. Well, right now they use immunotherapy, which has been shown to be, for her, she's not on chronic apheresis. She's on immunotherapy now for her CNS, for her lupus, and she hasn't had a problem since then. So I think immunotherapy is going to alleviate a lot of these needs for that NION. But it just shows you the benefit of this treatment, what it does to the vasculature. It's just dynamic. It really cleans out the blood in a way that's it's hard to understand. And it taught me to understand vascular disease much more by its ability of reducing that sludge of rheology that blood has, that can have, by the lipoproteins, inflammatory markers, and so forth.
Are we going to see more CLI patients, critical limb ischemia, So I'm one of the vascular medicine physician.
Okay.
So we see a lot of the critical limb ischemia patients.
Yes.
With multiple risk factors, renal failure, and then you name all, throw every kitchen sink at them. Still, they end up having all these amputations.
Right.
So are we going to see in the future this apheresis indication
Well,
and then the same in some of the limbs here?
Well, I can have the Conica people talk to you about that, but because they are getting ready to do a study here in the United States. They've been waiting for a long time, and hopefully in the near future they will. There's also another study that we're planning on doing that's in the works, is treating preeclampsia. There was a study done in Germany 10 years ago, was it now? Probably 10. And they showed that by using apheresis in preeclamptic women, they extended the pregnancy by 2 weeks. 2 weeks, which is life and death for the baby and the mother. So I say yes, I think they are. You got to ask them how they're moving ahead with this kind of proposal for the trial. But the data from Japan is so dynamic. What was interesting, they got approval for FSGS in the United States for pediatrics and now adults without any studies done in the United States. They based it all on their Japanese data, and the FDA was so impressed by it, they went ahead and proved it. So I don't know if they could do that for PAD, but I think the PAD is even more dynamic than the FSGS. And I don't know what their plans are. Does anyone here from Conica want to talk about that? No? Okay. Naoto, no?
no, not that one.
All right, well, when we break out, you can talk to them one-on-one.
So we've seen a beautiful family, and their future is going to probably be another family. And you have to think about long term. So what experience do you have in terms of guiding them for planning pregnancies, for fertility in the future with their condition? What experience have you had treating it during pregnancy? I mean, it looks like a lot of neat options are opening up.
We educate them on that, of the complications of intermarriage between two heterozygotes and so forth. That we do, but nothing to the degree that you probably do in your setting, because I see them for just a specialized reason. I'm not their primary care doctor per se. But my nurses and my dietitians and the rest of my team educate them. We have pharmacists that are part of my clinic too. But nothing that I can say definitively what we do. It's case by case. Oh, how much do I treat per? Not too much, to tell you the truth, actually. I know Linda Hampel had a nice case study done in Boston where she treated a pregnant woman with apheresis, and it's been done in many other places. And actually, after the pregnancy, they actually just kept on treating her during the breastfeeding period, too. So apheresis during childbearing period is safe. It's not officially approved, but the data shows it's pretty safe in situations like that, particularly for HoFH patients. Yeah, it is, and I've been pushing both this company and the other company that left the United States. B. Braun is no longer in the United States. They don't have the machines. So the only company approved for lipid apheresis in the United States is Konica. That's it. In Germany, they have about 5 or 6 different companies. Only Konica has been able to sustain it here and stick it out and to deal with the resistance to doing this in the United States. And I don't know why there's resistance. I mean, Germany treats 3,000 patients, and they're 1/6 our size. And we probably treat 300 in this country. Makes no sense to me. The preeclampsia, they did more often. They didn't do it every 2 weeks. It was more often. Look it up. It's in. Just go on Google, look at preeclampsia and lipid apheresis, and you'll find it.
With some of the controversy in the use of aspirin, is she on aspirin therapy, a daily aspirin therapy as well?
No, because she doesn't. We're treating her with the apheresis. That's more than sufficient. Now, my 11-year-old boy who had the stroke, he's on aspirin because of the LPOA. I think that primary prevention thing was too much of a whitewash. I think, as we know, primary and secondary, there's so many different grades between that. And I think high LPOA, family history, other things, I think warrants, as far as I'm concerned as a clinician, to start someone on an aspirin. What do you think, Seth?
Yeah. I mean, the big studies that came out recently were largely focused on that sort of the latter part of life, and folks, certainly the risks of bleeding seem to outweigh the benefits, but it doesn't apply to all clinical scenarios, and still have to use clinical judgment. I agree. It is interesting sometimes in medicine where we're doing one thing, and then these studies kind of switch, the pendulum another way, but probably the answer is in the middle somewhere, and you have to tailor things.
In your experience, what percentage of homozygous FH patients with defective mutation status, so not null mutations, still require apheresis after the introduction of PCSK9 monoclonal antibodies?
I see. So those that aren't completely knocked out or not null, that are defective, that would still need apheresis. What proportion? I mean, from any one clinic, it's like kind of hard to give a great proportion, because it's the denominator is so small to begin with. I guess if I think about my own personal clinic, I think there's 2 patients like you're describing who still require apheresis, but I don't know if you want to.
Well, Amgen did a study in South Africa that was published in HoFH patients and showed a modest reduction, not as dynamic as you would see in the heterozygote, but they did see about a 30% reduction. Am I right, Antonio? Yeah, about a 30% reduction in the HoFH that were not null receptor. Null receptors obviously had no clinical benefit because of the lack of response. But you have to remember, 20% of the world's population have a high LPOA. When you talk about FH, that goes up to 40, 50%. So that's a problem that I have with my patients. I put them on PCSK9s, the LDL gets down to a close range, but they still have the high LPOA. And what do? Do I stop? What was the major player for that patient's disease to start with? And because I got approval from insurance to get them on board, it'd be hard to go back at this point, maybe in the future when we get approval, that the insurance won't respond to the Lp(a) request. Yes, Dr. Wild.
It is sad that such great therapy is, widely used in one part of the world, but not so much here. What do you think the real barriers are? Are there issues of cost, comfort level? Any thoughts?
Well, cost-wise, it's covered by providers quite nicely. I mean, if you get approved by your provider, you're covered. Medicare covers it, and that's not a problem. It's an orphan treatment, meaning it's not. You think a nephrologist, a hepatologist, or a hematologist doing this, as you know, and those kind of clinics that do this, sometimes they fail because the patients are introduced into an environment that has a very negative environment, dialysis being one of them, where our clinic is 100% dedicated to lipid apheresis. That's all our patients do it. And it's like a family. We become like a family with them because they come back every 2 weeks. They get to meet our nurses. And in fact, we're having a dinner later this month of all my apheresis patients. Conic is putting it on, and we're going to have a dinner in Kansas City with their spouses and my nurses. And when is that, September 18th? Jen? Harry? September 18th. So if you're in Kansas City, come on by and look at that. So I don't know why. I think the NLA should be more proponent of this than it is right now. Because this is where lipidologists should be the standard bearers of this kind of therapy. And we're not as much as we should be. Jim Falco was he started the program in Colorado. It was really floundering. When he went out there, he really got up and running. And how many do you have now? And how do you get referrals for apheresis or Lp(a)?
I mean, generally the referrals come in for PCSK9, and then they might turn into apheresis. I don't think there's really a lot of knowledge out there. I think, like, to answer your question, it's sort of at different layers. It's like, number one, patients aren't getting identified. If 10% of FH is identified, there's problem number one. Then when they actually get diagnosed and they're in clinic, at the provider side of things, how many have an active program? We know even very prominent lipidologists who, that don't have an active apheresis program that they can even offer to a patient that's not even nearby. And then the question of cost, I mean, if it's covered by, if it's covered by the question of cost is sort of how much does it cost, and then how much is it out of pocket. And if you have good insurance and it's covered and you're not paying out of pocket, that's not an issue. But if you don't have people getting identified, and then you don't have providers that are offering it, if I'm hearing about FH patients who find out about it by going to an FH patient meeting, not from their clinician, that's an issue. So I think it's at multiple layers.
Yeah, I would like to compliment Dr. Moriarty because I've learned a lot from him. I went up to Kansas maybe a decade ago to learn how to do it and brought it to the University of Colorado. We had about 25 patients on apheresis, and since the new drugs have come out, there's only about 5 or 6 left. But I've learned a lot from him, and he's really a great source of information, not only nationally but internationally. Just a few weeks ago, I asked him about a patient who had dementia with high LPA and a relatively good LDL on a PCSK9, and we're working him up to see if we can get him on apheresis. A 50-year-old guy, perfectly well, who got Alzheimer's, that we think possibly might be related to the rheology that Dr. Moriarty described.
Pay you later, Jim.